welcome. I want to welcome you all to CHITIN's Cross-Border Healthcare Intervention Trials in Ireland. This is a celebration event. So we are going to be celebrating all the amazing work and all the amazing studies that you've all been involved in today.
It's a delight to welcome you to the CHITIN celebration event. And I've been saying this all day. Today is the culmination of almost 10 years of work. And this started with the partnership between HSC R&D Division and Health Research Board. I'm trying to avoid the acronyms for everybody. And we targeted a superb funding opportunity offered by the Interreg 5A programme via CHIPBe, which enabled the support of 11 innovative trials of novel health interventions across Northern Ireland and the border counties of the Republic of Ireland. So that was a great thing. That was a first for us both as funders. It was of great significance to us. It was an unprecedented opportunity to support a series of trials in our mutual areas of priority and to build a network of research collaborators and to support research taking place in settings and among populations in which it was not our custom and practice to be able to support. So for that, I first want to sincerely thank the EU Commission, the CHIPBe, and our Department of Health sponsors in both Northern Ireland and the Republic of Ireland.
And I'm just delighted to be here to take part in this wonderful event to celebrate CHITIN. And I mean, it's such a shining example of collaboration and innovation in healthcare, and has made such a difference to people on both sides of the border in terms of their health outcomes, and by providing access, equal access to health intervention studies. But this would not have been possible without the long-standing collaboration between the Health Research Board and the R&D Office within the Public Health Agency. And this has been going on a long time, and it is really, our collaboration and partnership is really grounded in a common goal to support high-quality research and collaborative research across the island of Ireland. And we really are very determined to continue this partnership, to build on the expertise, capacity building, and the wonderful work that has taken place throughout the CHITIN project. I want to thank my colleagues that were really instrumental in making this happen, and they include Patricia Clark, Anna Cody, and Mairead O'Driscoll, our current CEO. They helped put everything together and really deliver on this, so I really want to mention them today. It has not been a smooth journey, and we've touched on some of the challenges, not least a global pandemic. And that doesn't even, mention the navigating, two jurisdictions to deliver on research activities. So we really want to explore what the learnings and the experiences of all the research teams, and we're hoping to discuss them during the panels today. So the HRB and the Public Health Agency are proud champions of public and patient involvement in research, recognising the immense value of including other perspectives and the experiences of those that are directly affected by research. And the CHITIN project really placed such a tremendous emphasis on this PPI activities, and they supported the researchers to really seek input from patients, families, and the broader, wider public. And there has been some stellar examples of these kind of activities, throughout all the projects. And really, I believe that there's no doubt that they have enhanced the activity, the relevance, the impact of these health interventional studies. And again, we'll touch on these during the panels later.
And the Interreg programme is one of 70 across the whole of Europe, because they specifically are there to address the challenges of a border. Because there are some challenges, obviously, mostly geographical challenges in terms of the region and the peripherality, but also the limiting opportunities that it offers citizens who live in the border, particularly in relation to access to services. So that's why in this Interreg 5A programme we had a specific measure which was to fund health and social care as a particular area of focus to allow people and citizens in particular who would not normally ever get a chance to be involved in these trials or to get access to this type of healthcare to be able to do that. So really that's the purpose of Interreg funding. It's to provide equity of opportunity for everybody on the island, and particularly in the border regions, because border regions are generally across Europe regarded as the most underdeveloped regions nationally within boundaries. And health is viewed as an economic sector representing around 8% of GDP. So socioeconomic conditions such as those then lead to disadvantages for the region, the cross-border region, for development in many, many areas, and access to healthcare is a challenge and specifically then results in inequality. And we all know the difficulties of rural citizens who have to get access to healthcare. So I really want to congratulate Public Health Agency in Northern Ireland and the Health Research in Ireland, who have such a wealth of research experience and have really delivered on this partnership, because obviously if partnerships were easy, we wouldn't be here funding them. They do represent challenges, and everybody's got their day job, so to be able to come together and do the cross-border partnership is incredible. And then to deliver this kind of ambitious and innovative project, prioritising research in physical health, both mental and physical health, is something then that we're very, very proud of, and obviously want to congratulate the Departments of Health in Northern Ireland and Ireland, who have also given us a lot of not just financial support for this project, but also administrative support.
Anyway, I think we don't celebrate enough our successes in research, and that's why I think it's particularly good that everybody has gathered together today to celebrate the success of the CHITIN project. As Janice said, it's been a 10-year journey, and there's been a lot of work behind the scenes. There's been a lot of work by the researchers, and not just the researchers in isolation, but researchers working in partnership with patients, participants, members of the public. And that's been something that's been critical to the success of CHITIN, because we hope, firstly, that the impact of some of your work will continue, that it will influence policy, that it will influence how care is given in Northern Ireland and in Ireland overall. And we hope that it will make a difference, and you will all still have a role in terms of trying to ensure that that impact is properly picked up. And we also hope very much that the collaborations which you have developed, working together, will continue, that you'll find ways of accessing other funding streams and developing and building on the relationships which have been an important part of the CHITIN project. Certainly at Department of Health level, we work closely with our counterparts in the Republic of Ireland. At a funder level, Public Health Agency, CHIPBe, HRB work closely together in terms of thinking how we can support research which will have real impact. We will continue to do that, and we hope that you will continue to do it as researchers and research communities. I can't help but comment briefly on the challenges you faced. None of us, when CHITIN started, anticipated the enormous changes that would occur. And I know that many of you had to modify your projects and work as a result of that. And those of you from Northern Ireland will know that COVID became essentially dominant in my life for a couple of years in terms of my work. And the COVID inquiry has just launched today in London, and will run for the next 2 or 3 years. It will reflect on the challenges and the harms that came from the epidemic and its consequences. And research and the impact on research will be discussed, I know, as part of that. And I think what we've learned is a couple of things. Firstly, how resilient researchers are in terms of adapting whenever challenges appear and take place. And secondly, the extraordinary importance and value of research, which is designed to address important public health and clinical questions and is conducted in a timely way, and how, when we really put our minds to it, we can approve a research study in 3 days. You'll find that hard to believe, I know, but anyway, it really happened during COVID. How we can recruit patients within a week, randomize them to an intervention, and get results in a few months which completely change practice. That's what we aspire to take from COVID and try to implement in the post-COVID world. And I hope that you will all be part of that in whatever area of practice you're working.
Good morning, everybody. I'm Suzanne McDonough. I'm a Professor of Health and Rehabilitation. I was based at Ulster University when I got this funding, and now I'm based in Royal College of Surgeons in Ireland. And our study was a feasibility study to test the feasibility of a behaviour change intervention to increase physical activity and sedentary behaviour in people with severe mental illness. So these are people who have enduring mental illness and have significant challenges in day-to-day life. And it was I can tell you more about the project, but we had 60% of our population had cognitive challenges. So lots of interesting findings in our study.
Thank you.
Hi everyone, so my name is Bridie Kim. I am a research nutritionist and I was working on the Page 2 study, which was a pregnancy and postnatal intervention for overweight and obese women with gestational diabetes mellitus, or GDM, and we were looking at weight reduction at 12 months postpartum. So we began the intervention during pregnancy between 32 to 36 weeks gestation. And then we took several time points throughout the intervention, so 6 weeks postpartum, 6 months postpartum and 12 months postpartum, and measured mothers' physical activity levels. We measured their dietary intakes through phone calls with dietitians and research nutritionists, and we also took blood samples then to check glucose levels, lipid levels, and electrolytes and urea throughout the intervention. With the hope that these mothers then would hopefully lose some of the weight that they gained during pregnancy at 12 months postpartum.
Hello everyone, I'm Professor Michelle McKinley from the Centre for Public Health in the School of Medicine, Dentistry and Biomedical Sciences at Queen's. So I've been working on the HHIPBe study, the Healthy Habits in Pregnancy and Beyond study. And this study was a feasibility study, and it aimed to see if we could embed healthy habits intervention in antenatal care, working across 4 sites in Ireland, 2 in the north of Ireland and 2 in the south of Ireland. So the first thing that we did was take an existing intervention, the 10 Top Tips intervention, which is based on 10 healthy habits around diet and physical activity behaviours that have been shown to help assist with weight management in the general population. So we wanted to take that and adapt it for pregnancy, because more than 1 in 2 pregnant women enter pregnancy with overweight or obesity, and there's a lack of services for women to support them during pregnancy and into the postpartum period. So our work involved, first of all, adapting the intervention with PPI input, understanding the antenatal care pathways across our 4 partner sites, and they were all very different, and then developing our protocol according to the antenatal care pathways across the 4 sites, so that we could really do our best to implement the intervention into existing antenatal care pathways. And we encountered the same challenges as other people, but we were able to implement the intervention and had really good feedback from women and health professionals.
I'm Richard Costello. I'm a Professor of Respiratory Medicine in Dublin, and I was part of the Inca Sun team. The aim of the Inca Sun was to address the needs of people who have uncontrolled asthma. And what we did was we did a randomized trial where we compared the outcomes of clinical decisions and medication adjustment when physicians used digitally obtained information as opposed to the conventional information that's used at a clinic for adjusting medicines. And what we found was that we actually reduced, so we had better medicine supervision, and we reduced the escalation to very expensive biological therapies for people with asthma. On average, amongst our 200 participants, there was a €3,000 cost saving amongst the people who had the digital intervention as opposed to the conventional one. And we think, and it was particularly inspired by our experience in CHITIN, that the increase in access, that using digital technology as opposed to sort of the conventional therapeutic approach that would require a specialist centre, it showed us that we could really use this type of digital technology to enhance access to medicines for people in more remote communities, such as were particularly brought to us in CHITIN. So that was a particular finding of this study for us.
Okay, thank you. I think Amanda and I have a couple of questions for you as panel members. So I'm going to kick off, well, I'm going to hand over to Amanda for the first question.
No problem. I suppose today we're just, for this panel, we're concentrating on collaboration, and we all know that collaboration is absolutely key to delivering on research, but and very importantly on health intervention studies. So, and we know that CHITIN has really secured and built upon existing relationships and collaborations, but also created new ones. So we just wanted to see, from your perspective, your experiences, what has the CHITIN project enabled for you? Was it new, or was it the development of existing collaborations? And that can be across disciplines, across border, so we'll leave it up to you to share. So I'll just ask maybe a couple of you, and then we can move on to Suzanne, if you want to take.
Sure.
That'd be great.
Yeah, I'd say this was a new collaboration. My sister's a consultant psychiatrist. This is how I ended up working in this area. She'd always wanted to improve the physical health of her patients, and so this CHITIN funding really gave us the opportunity to do that. So it was very much a collaboration across disciplines, so between physiotherapy, occupational therapy, and the psychiatry staff, and then also the cross-border elements. So we have built collaborations which we hope we can harness for the future.
That's wonderful. That's great. Great to hear that it's literally cross disciplines, cross border as well, which is fantastic to see that this project has enabled that. And yourself,
Yeah, so again, I think that this was quite a new collaboration. We were very fortunate that we had a pilot study that was conducted in the north of Ireland, and so then the next step then was to obviously try and extend that to the north and south of Ireland. We also then tried to collaborate within, similar to yourself, Suzanne, where we went to interdisciplinary. So we had nutritionists and dietitians, we had nurses and midwives, and Professor McCants, who was the PI for the page 2 study, is a consultant endocrinologist. So we had quite a multidisciplinary team within the research project itself, and obviously had the cross-border collaboration.
Okay, great. I think we have time for another.
Yeah, I think so.
Michelle, do you want to just give us an indication of what new, or whether your study was a culmination of previously or existing collaborations?
Sure,
or new ones?
Yeah. For us, it was all new. Okay. So this, when this funding came along, it was a really lovely opportunity to spread beyond where we usually had collaborated and where we had usually gone in terms of our collaborations. And in the south of Ireland, we were working in Our Lady of Lourdes and Sligo University Hospital. In the north, we were working with Altnagelvin and Belfast, so really spread throughout all of Ireland. I suppose that was a lovely part of it, was building those initial collaborations, clinical contacts. Mm-hmm. But then what really stood out for us was maintaining them throughout everything, all the ups and downs. COVID that completely turned healthcare on its head, delivery of antenatal care services had to change overnight virtually, but all of our clinical partners across the sites remained engaged throughout the whole time, lockdowns, not in lockdown, back in lockdown, and they all 4 partners remained engaged with us throughout the whole process, and we're very grateful for that, and we will definitely seek to maintain those collaborations in the future.
That's fantastic. Even when the healthcare were literally on its knees, to see that they were still engaged in the research is fantastic. I feel like I'd be leaving Richard out if I didn't ask him.
Yeah.
Well, I think if I was to talk about a collaboration that perhaps we haven't mentioned today, it was actually with the R&D offices locally that I was really impressed with, that a lot of people who took on the challenge of doing trials were obviously the clinical facing people and the patients. But back end, the folks who were involved in regulation and administration, they hadn't really had that experience. And I have to say that collaboration was really successful. There was a lot of open doors, and I guess I think that was a surprise, because you sort of would tend to think that they would have to sort of build up a new muscle memory. And I think that kind of echoes with the idea that healthcare professionals, and that's everybody within that sector, are actually much more adaptable than we might have given them credence for, as shown by their preparedness to change when the pandemic came along.
Yeah, I think the research ecosystem is much broader than just
Precisely.
the actual research team, the clinicians. It's actually
because everybody was motivated to see an impact in their hospital for their community.
Yeah, no, that's wonderful. Pass over to you, Janice, if you want to.
So I think you've covered quite a lot of what we had intended to ask already, but just to ask you very quickly, what would be your most important learnings for cross-border collaboration, or collaboration more broadly, from this programme for the future? And I'll start with Richard this time, since you went that direction.
Well, I think there's three things that it struck me. The first is that there's a group of people here who've done interventions in different fields, but there's an awful lot of overlap. And if there was some way to kind of capture the synergy of the work in these future studies, I think that would be useful, so that the muscle memory that this group have achieved would be tremendously worthwhile, so that you build on the themes of the interventions. That's obviously one future learning. There is the regulatory piece is difficult between the two communities. I guess that's the whole idea of cross-border research. But that was a challenge. Everybody knows it. It does slow one down. I'm not sure you can really change that. But recognizing it maybe in budget impact time or study lead-in, I think that would be worth thinking about how you design the grant funding piece. They would be my two take-home messages.
Thank you. Michelle?
So I'm trying to think of just a couple of main things. I guess one piece of learning for us is probably around, just reinforcing for us the importance of the PPI element in research whenever you're starting to build it. It wasn't just working with women who had experienced excess weight and had recently been pregnant who helped us design our materials, etc. But also broader, working with clinical teams to understand their perspective, what they're faced with on a day-to-day basis, and then you're adding research on top of that. Whilst we initially set out to design our research to be as least burdensome for the healthcare staff, COVID changed that, and we had to amend our protocols, and that definitely placed more burden than we would have liked on the healthcare staff. But I guess it's that piece of work around broader PPI and understanding the context you're working in, and the importance of that being properly funded, because it adds to the timeline of your project, but it's really important for us to do. So I think, working with funders, we need to get better at building that in properly in a meaningful way, and understanding that it will elongate the timeline of your research, but it's worth it ultimately.
That's good to hear, and we're really supportive of that.
I think I would just like to reiterate what both Michelle and Richard have said in terms of, the wider PPI and, the different sites and stuff across the south. I think one of the biggest things for us on the Page 2 project was that communication kind of broke down with our southern sites because of several issues. COVID, being the biggest one, and then obviously cyber attacks. And then for us, unfortunately, as well, just with that difference in the north and south healthcare systems, because we were recruiting women with gestational diabetes, some of the southern sites ended up using different diagnostic criteria to us in the north, which then ended up, we had to eliminate those sites. And so there was, I suppose for us, one of the biggest things going forward would be just that, as much as where we can, where possible, that continuity of healthcare systems and diagnostic criteria.
Suzanne. And just to finish, I suppose there's two things. One is that there was the silver lining with COVID, that we all had to pivot to remote, and certainly we were a little bit nervous given we had people with cognitive challenges, but actually worked really well. And then I think the second thing is and Richard has mentioned it already, we have built these collaborations. We've supported clinicians who have not been involved in research before, and it's really important that we harness that and make sure we don't lose all that kind of capacity that's been built.
Hello everyone, thank you very much for the invitation. So I'm Claire McAvoy, and I work in the Nutrition Research Group in the Centre for Public Health at Queen's University, and I was co-investigator on the brain diabetes study. So this was a multi-domain lifestyle intervention for people with type 2 diabetes living in rural border regions. So our target regions were Sligo and also Tyrone Fermanagh. And we were inspired really from a proven intervention, the first large-scale intervention that was conducted in Finland to show improvement in cognition in people who adopted a lifestyle intervention, in people who were high risk for developing dementia. And we're focused on people with type 2 diabetes because we know diabetes is a risk factor for dementia. People with diabetes have 2 to 4 times the risk of developing dementia in later life. So for us, this was a particularly high-risk group. So the aims of our study were really to adapt this proven intervention for the Irish context, for people with type 2 diabetes, and then to test the feasibility of that. And actually, despite all the challenges, we were able to recruit and retain people into the study. They made the lifestyle behavioural changes that we were looking for, and they also experienced improved health outcomes in terms of their BMI, their triglycerides, and also the quality of life measures that we included in the trial. And they reported high acceptability, saying that they would recommend the programme to friends and family with diabetes. So we were very encouraged by that.
Thanks, that's great. And Kevin, if you can just...
Yes, good morning. So I'm Kevin Brazil, and I'm a professor of palliative care in the School of Nursing and Midwifery at Queen's University. And I was the lead for what's called the Anticipatory Care Project, which can be described as a primary care preventative intervention for older adults who are at risk of functional decline. And what that consisted of was that we would go through the practices, identify those individuals, screen for those individuals who sort of fit a certain criteria, which was multiple illnesses, multiple medications, etc. And then we would assess those individuals on something called the PRISMA, which is a sort of an instrument which is predictive of functional decline. From there, a nurse conducted a holistic home assessment, which was person-centered. From there, they would generate a list of recommendations based on that holistic assessment, and also do a medication review. And they would link to a clinical pharmacist who would review those medications, make recommendations. That profile or report was then shared with the general practice and also shared with the patient and family, and with recommendations in terms of additional supports. The whole idea behind the intervention was to really sort of find those individuals in the community who are flying beneath the radar. And if we get the supports in a timely fashion, we can avert adverse consequences further down the road. This was a feasibility study, and we did demonstrate, we published about 5 papers from this exercise, quantitative and qualitative, and certainly from a stakeholder perspective, that being families, patients, service providers. It was well received. It was valued in terms of the model of care. The outcome measures were robust. We did find some tilts in the right direction, but we were deliberately underpowered. And we did sort of, in terms of progression criteria, we did sort of satisfy that progression criteria in terms of moving towards a full trial. So it was a successful experience, and fortunately, it was a study which was first off the blocks and first to finish. So we just kind of missed COVID. We had to do some quick arrangements moving in terms of a social distance protocol, but we moved back into the office. We came out of the field when COVID became very bad. So that's the ACP and who I am.
Thanks, Kevin. You were one of the lucky ones, I think.
Hi, my name is Elaine Murray. I'm a senior lecturer in the School of Medicine at Ulster University, and I was the principal investigator for the SPIT study, Student Psychological Intervention Trial. So our study really had two separate phases. The first phase was to conduct, as part of the International College Student Project, to conduct an online survey looking at prevalence rates and various risk factors for mental health among the student population, which was conducted both at Ulster University and Letterkenny Institute of Technology, which is now ATU, Donegal. And at the same time, we also collected saliva samples to look at biological markers as well. The second phase of our study was to conduct a randomised controlled trial to test the efficacy of an online cognitive behavioural therapy based intervention to improve the symptoms of depression and anxiety, so mild to moderate anxiety and depression in students. The intervention that we used was a coach supported online intervention that had been developed previously by our colleagues in the Netherlands and was adapted for use within the student population in Northern Ireland and the Republic of Ireland. And our intervention group showed significant improvement in both depression and anxiety immediately following the intervention. We also are seeing sustained improvements in the depression scores 6 months following the intervention. So we're very pleased with the way that the intervention turned out.
Thank you, all of you. And through the programme, we were keen to support research across a range of populations and settings. And I think that you three of you have demonstrated a great example of that. So I just have one more sort of question, and I'll give you quite a lot of scope of how you reply. Within that setting and within your population, did that present any opportunities over other settings or populations, and what were the key factors to your success? Start with Elaine.
Yes, I suppose ours is unique in the fact that we were dealing with a student population, and in a university setting, I suppose you have a fairly captive audience if you're working with students from who are registered in particular institutions. I think the challenges around that can be around engagement and to get in students to take part in research. So we had a few different kind of strategies for improving the uptake. So we had conducted previous research and realised that that you can get an agreement to take part fairly easily, but as soon as they walk away, it can be hard to keep them involved in the study. So we this time asked students to complete the survey at the time that they signed up, and they were given a university branded hoodie as an incentive, which we found worked really well, and also we were able to give vouchers for participation on the intervention. So I think that was good. In terms of why it's good to do research within those settings, I think it's an opportunity where, particularly for mental health, that we have the opportunity to identify students who might be struggling with their mental health issues and provide supports. And we had found in previous research that students might be reluctant to access the university student services. So this was a way to trial a slightly different version of support. It was an online peer-supported intervention, and we didn't plan that COVID would happen in the middle of it, and everything became online, which was a bit of a challenge, but we do think that it does have some, we have evidence that there is benefit in maybe offering this alongside the other support services.
Thank you. And Kevin?
Right. It's a tough question, but I think that really the passion and commitment on several levels, one being the investigating team who saw the intrinsic merit of what we were trying to explore, the research staff and the research nurses who really bought into what we were trying to do, and on occasion how the research staff literally would disappear for several days, and since they'd go out into the field, they'd book hotel rooms to collect their data and conduct their interviews, which was I thought quite exceptional. The nurses themselves, I mean, some of these home visits were in really remote areas inside of mountains without cell phone, going into a small convent. Like, it was extraordinary where these individuals went to find these individuals in the border counties, in largely rural, somewhat isolated communities. And so you needed passion and commitment to the process to carry that out. Also, I think that the practices themselves, you could probably describe them as early adopters. The practices themselves saw that, the GPs, they saw that this would help them or help their patients. And so I think that was their motivation for signing on. So I think there was a shared vision with respect to stakeholders in terms of what the merit of the initiative was all about, which sustained it through some of the obstacles which we ran through, including COVID.
Great, thanks, Kevin. And Claire, finally?
Yes, so we focused our recruitment for older people with type 2 diabetes living in the target areas. And I suppose for us at the outset, and Professor Peter Passmore is the PI for brain diabetes, and he had the vision and the knowledge that we had to have partners who were really well connected and deliver diabetic services for people in those communities. So actually our partners in Sligo and in Tyrone and Fermanagh were delivering diabetic services for people, and those were our most successful recruitment strategies, actually going through outpatient database screening, sending out letters and inviting people to take part in the research. And we also were connected with some of the charitable organisations, like Diabetes Ireland, for example, who were really, really helpful with recruitment for our study. And also, our study was actually delivered in 2 phases. So phase 1 was very much engaging with the target population to try and understand some barriers to the uptake of a lifestyle intervention and how we could improve acceptability. So having their insight and knowledge helped us shape the actual intervention design. So PPI was a huge part of the intervention development process, and I think that's ultimately what helped us meet our recruitment feasibility targets.
Great, thank you very much.
It's great to hear. It speaks back to our previous panel about collaboration and how actually building on those links that really help with the recruitment strategies. I mean, I suppose it all kind of links in together, identifying, these diverse, if you even have these diverse populations, but having access to the patients is absolutely key. I just have one question for you, Kevin, in terms of the GP practices. I know, there's been a few of the studies are, working with GP practices, and I mean, I think there are challenges in terms of their workload and their engagement with research. But did they have? Were you taking work off them, or you said that they saw the benefit of the research to really helping with their role, I suppose. But was there any reluctance at all in terms of engagement in research from the GP practices at all? Or is there anything that anyone here could benefit from your experience with engaging with GP practices going forward?
Well, I think the landscape has changed significantly from when we were in the field, which was, I don't know, maybe 3 years ago. Mm-hmm. I think things have changed very quickly and very dramatically. So the comparator from then and now, I think, is very different. And so I feel fortunate that we were in the field at that point in time. But also I think that when it's working with the GP practices, it's key. Like the intervention was geared to sort of where the research nurse would actually sit with the GP himself or herself and share these results. But there was a recognition that there were gatekeepers in the practice. It could be the office manager or other staff members. So the GP can be mediated by other individuals in the practice. So you have to look at the practice holistically and adjust your expectations in terms of what type. And I guess you have to adjust your expectations based on the contextual factors of each individual practice in terms of how it operates. Some practices, their filing system can be a shoebox. Other ones can be elaborate electronic systems. So some are new systems, some are old systems, or old practitioners. So you really have to customize your engagement to suit the personalities you're working with.
That's excellent advice for people. I mean, that's a lot to deal with, really, isn't it? Yeah. On a case-by-case basis per GP practice. So, yeah. But yeah, I suppose they are some of the practical challenges that researchers are facing. So thanks for that insight. Okay, I think, is that everything from us, Janice? Or have you got any burning questions remaining?
I think we'll say thank you to this panel now, and of course there's going to be more questions from the floor later on, but we've another panel to come, so thank you so much.
Thank you. Thanks very much. Thank you, folks. So that is panel 2 of 3, so we've got one more panel to go, and we do have a Q&A session at the end as well, so if you have any burning questions, you will get an opportunity to ask them. So, last but not least, we are on to panel 3, so if we could get Reflex up here, PolyPrime, also featuring PPI, patient and public involvement, with the WISH and My COMRADE Plus. So can we get a round of applause as they're making their way up here? Come on ahead. Everybody walks very briskly here. It's like, there's a researcher's walk. Look at that, confident, love it. Fantastic. He's not quite mastered it, but doing well. How are you? Like your tie? Okay, so have we got everybody? That was quick. So everybody grab a microphone in front of you there. A couple of people in the end might need to share. So we're going to be looking here at building capacity and capability in health intervention research. So good luck, folks.
Okay, and just similar to our last panel, if we could each introduce yourselves to the audience and just give a few lines about it, an overview of your study, that'd be great.
Good afternoon, everybody. My name is Carmel Hughes. I'm an academic pharmacist. I'm based at the School of Pharmacy at Queen's in Belfast, and I led the PolyPrime study. And it just became known as PolyPrime because the full title was just way too long. The study itself was focused on older people being cared for by general practitioners, and we focused on the use of multiple medicines. And it's long been recognised that older people, because of the number of medical conditions they have, will require a number of different medicines. There's been a concern, I think, in the past that perhaps older people receive too many medicines, and that sometimes can be the case, but sometimes they also don't receive the medicines that they need. So this study was focused very much on trying to ensure the appropriateness of the medicines that older people received, and the CHITIN study, PolyPrime, was built on some preceding work where we had developed a new approach or an intervention that was based on behavioural change techniques that were targeted at general practitioners to encourage them to prescribe appropriately. So we had done quite a bit of developmental work, and CHITIN gave us the opportunity then to expand that developmental work to south of the border, as well as carrying out the study in the north. So we did some refinement work of what we had already achieved in Northern Ireland, and then we rolled out our intervention in the form of a feasibility pilot study involving practices both in the north and the south of Ireland. And the intervention consisted of a video that GPs watched that basically described how you would go about prescribing appropriately for an older person. This study was very much about, can we recruit practices, can we recruit patients, and can we retain them, and then can we collect data, and what do the GPs and patients think about it? So as with all of the studies, we were impacted by COVID, so that did have somewhat of a negative impact on what we were able to achieve in our study, but I think we were able to show that we could recruit, that we could retain, that we could collect data, and that GPs were receptive to the intervention, as were patients, but we still don't know at this point whether or not it's effective, so hopefully we will continue the journey with PolyPrime and end up answering that question some stage in the future.
Thanks, Amelia. Carmen, that's great.
Hi, my name is Leanne Doherty and I'm a research fellow at Ulster University. So I was one of 2 trial managers on the Walking in Schools study, also known as WISH. And I suppose WISH was informed by a pilot study that was carried out by Dr Angela Carlin, who's one of the collaborators of WISH, where she ran a school-based walking intervention over a 12-week period, and it showed positive impacts on the girls' physical activity levels. So WISH was informed by the pilot study. We had planned to run the WISH study over 2 phases, phase 1 and 2, and to recruit schools over the 2 years, but unfortunately COVID shut down both of those years. So we then had a bumper recruitment on our 3rd phase. So the aim of the study was to evaluate the effectiveness of a novel peer-led walking interventions that was delivered across the school year at increasing adolescent girls' physical activity. So we recruited 18 schools across the border region from Northern Ireland and the Republic of Ireland. And those 18 schools were all recruited in that 1 year. We very much had PPI embedded into the WISH study from the planning stages right through implementation and dissemination as well. So I think we'll be talking a bit about that today as well. Thanks, Liam.
Hello everybody, my name is Tyke Stapleton and I'm an Associate Professor in Occupational Therapy at Trinity College Dublin, and I'm part of the REFLEX trial with my colleague Alison. So you will have seen in the video earlier on, we were looking at the upper limb interventions for people after stroke using a mirror box. And we had 3 sites here in Northern Ireland, in Enniskillen, Whiteabbey and in Newry, and then 2 in the Republic, in Dundalk and Drogheda. And we were trying to recruit people with stroke in subacute and acute rehabilitation to offer them the mirror box intervention alongside their existing therapies. And we were badly impacted by COVID because we were actually trying to recruit people in the acute stages of stroke recovery, and it had to be a face-to-face intervention in the hospital setting. And then we were continuing and following the people up 3 months after their discharge. So because we were so badly delayed with COVID, we had to keep recruiting right up until the very end. So we were just recruiting our last patients at the end of January this year. So, and we've just completed the 3-month follow-up. So based on the preliminary data that we have, even though we're underpowered, we do see that there was, the trends are looking positive and that we saw better improvements in the intervention group compared to the control group. So that was our study.
Thank you, Ty.
Hello, everyone. I'm Alison Porter-Armstrong. I'm a Professor of Healthcare Technology, Innovation and Assessment. At the time of the award being made, I was at Ulster University, and I'm now based at Edinburgh Napier University in Scotland. As Tag has said, we're part of the REFLEX team, and as I led that study setup, we delivered training to about 80 therapists. And we realised very quickly that as we trained therapists in each of the 5 sites, that the training was being so well received in all aspects of the research protocol, whether that was on consent or ethics or the intervention or the outcome measures that we were using, that we could probably roll that training out. So we submitted another application through the office and requested some additional funding to run what became known as the extension activities. So we had 2 strands to that. We delivered a boot camp, an annual stroke boot camp for 2 consecutive years, and trained another 805 therapists through the boot camps. And then we also offered a range of 6 standalone MSc level modules for therapists who really wanted to consolidate their skills in a more formal way. And we offered close to 400 places on that programme as well. So it's been a very busy couple of years for the Reflex team, but we have that opportunity to capacity build is really transformational for allied health professions across Ireland. We have never had those opportunities. We've never had that opportunity to acquire the knowledge and skills in a fully funded way before. So that's our experience and a little bit about how we've contributed to capacity building in this area.
Thank you.
Hello everyone, I'm Laura McQuillan. I'm a GP and I worked on my COMRADE Plus study as the GP Research Fellow in Northern Ireland. My counterpart Sarah Milligan is a GP in Galway. So my COMRADE Plus study really was building on previous work done by Dr Carol Sinnott looking at a collaborative medication review. So we know now that patients are living longer with lots more medical complexity and are on a lot more medications than they would have been. So we really looked at patients who are on 10 or more medications in 15 practices across Northern Ireland and in counties Donegal and Sligo. And basically what we looked at was to see really the feasibility and acceptability of doing a collaborative review. So in Northern Ireland, since 2016, every GP practice will have a practice-based pharmacist. So in Northern Ireland, this collaborative review took place between the practice pharmacist and one of the GPs, basically sitting down, looking through medications, reviewing any inappropriate prescribing, etc., and how medications could be rationalised and things like that. And then in the south, then because they don't have practice-based pharmacists there, the medication review was conducted by 2 GPs. And really, the results show that both patients kind of find this very satisfactory, having their medications reviewed by 2 professionals in the practice, and it was also acceptable both to GPs and practice-based pharmacists. So we'd be keen to build upon this work going forward.
Okay, thank you.
I've got a question just in general. I'm struck by the diversity across this panel of different professions represented here, healthcare professions. And one important element of the research that we really wanted to build on was how training was provided for researchers, healthcare professionals and participants with a view to building capacity for the future. So can you just elaborate a little bit on the capacity building activity that was conducted as part of your project? And I'll start with you, Laura.
Yes, so we involved some practices that had previously done research and would have had experience in that area, but we were very keen, certainly in Northern Ireland, to involve practices in the West. So kind of practices in kind of Fermanagh and kind of dairy and things that traditionally would be underrepresented in research. So we were very keen and they were certainly very engaged. And we found the practice-based pharmacists were very keen to get involved in research and certainly would be keen to kind of build upon that in the future. In terms of delivering training, we went out to practices. A lot of the relationships certainly that we had with practices in the north were existing. And say, I think nothing really beats going out to a practice and kind of delivering things face-to-face, but obviously that was impacted by COVID. So in terms of kind of teaching staff, and that's everything from practice managers, receptionists, everyone is kind of involved. If there's research going on in a GP practice, we did a lot of that on Zoom, so we were kind of a bit more au fait with Zoom even before COVID, thankfully, so that was very useful.
So the boot camp, I'll maybe talk about that first. So the boot camp that we delivered was originally planned to be delivered in person as a face-to-face event. And because COVID fell upon us, we very quickly had to pivot to an online delivery. And at first glance, we weren't sure that we could actually deliver the boot camp in that way, because we really wanted to do a lot of hands-on work. We wanted to demonstrate the mirror box. We wanted to actually use the outcome measures. But we were very fortunate through the funding to be able to secure a professional AV company to help us deliver it. And actually it worked really well. For 2 key reasons, I think. One, we were able to advertise the event to therapists no matter where they were. So although we were focusing on therapists from Northern Ireland and the border counties and Southern Ireland. We actually had delegates join us from as far afield as Malaysia, Singapore, Hong Kong, who wanted to also acquire some knowledge and skills. So that was a great bonus to really be able to deliver something from Ireland that was truly international. I think that hadn't been done before, so we were really pleased to have been able to do that. It also allowed us to extend the range of experts that we were engaging with to deliver the training, because the geographical barrier was totally removed. So we had in the first boot camp 40 different speakers, and in the second boot camp we had 31 different speakers, and those speakers weren't all from the UK. We had speakers from Finland, we had speakers from Canada, America, Australia. So we were really fortunate with the richness of the training, and we wouldn't have been able to provide that if it hadn't have been for COVID and pivoting to an online delivery. So that was a bit of a silver lining for us. In terms of the master's modules, they were all being delivered online. And again, we had a really good reach right throughout Ireland, but obviously we were focusing on the border region and Northern Ireland. What we found with it was that we were able to secure registrants for a much broader range of allied health professionals. The stroke boot camp was focused using a rehabilitation model of practice, so it mostly appealed to occupational therapists and physiotherapists. We had some orthoptists and some speech and language therapists join us, but it was a much more restricted population, whereas the master's level modules have been taken by a very diverse population of AHPs, including dietetics, paramedics, which we know there's a great deal, a great need to train up. So we were able to get a broader reach through that aspect as well.
Great, thank you. Pam?
And I might just add to what Alison was saying on the reflex trial, because we also did a lot of pre-training for the sites that were involved in the research, because I think it's fair to say with occupational therapy that it's probably the first time we've had cross-border collaboration between Ulster University and Trinity College. And involving occupational therapists in this type of research. It's probably a profession that isn't as well research active as it could potentially be. So I think we did a lot of training on the sites where people weren't necessarily familiar with or used to doing this type of research. So I think that built up a lot of capacity in just understanding how to implement a piece of research into clinical practice, and hopefully skills that we'll be able to take forward in future collaborations as well.
Yeah, absolutely. Thank you, Leanne.
So I suppose we were very fortunate and wished that we had quite a large team. So there were learning opportunities and upskilling opportunities right from the collaborators down to the trial managers, research students, and also the research participants as well. So just to mention in regards to the collaborators, it was bringing people together from Ulster, ATU in Letterkenny, University of Wolverhampton and Bristol. A previous PhD student of Marie Murphy was Maria Faulkner at ATU. So it particularly was beneficial for her to be able to build on that relationship and that cross-border relationship with ATU now and Ulster University. Then in regards to the trial managers, myself and Maria had an opportunity to attend different conferences and undertake different training as part of our role. We were also very fortunate that each year of WISH, we were able to recruit 2 placement students to the team. And I think this was an absolute amazing opportunity for the placement students. They had an opportunity to see the world of research, the diversity and how no 2 days are ever the same. We actually had one of the placement students go on and start a PhD. So she's doing her PhD with Marie Murphy and the medical school at Ulster, and another student who was applying for a PhD as well. So they were building these research skills, but you can't underestimate all those transferable skills that you develop whenever you're working as part of a research team. And they are so key for those students as they then pursue their future career. Then thinking about the actual research participants. So as part of the Walking in School study, we went in as trial managers and we trained up older girls within the school to be walk leaders. So it was actually the older girls within the schools that led the younger girls in the walks at break time and at lunchtime and before school. So in order for the walk leaders to be able to undertake this, we provided walk leader training. So over the 3 phases of the WISH study, I think there was nearly 270 young girls across Northern Ireland and the Republic of Ireland trained as walk leaders. And some of the feedback that we're getting from the walk leaders was that it really helped develop their leadership skills. It's something that they were able to use on UCAS applications and put on their CV, and it helped them integrate more within the school setting. So we had a very large team, and I do feel that each individual benefited in some way as part of being a part of the WISH study.
That's great to hear. And who knows how many future researchers we have created in those schools.
It's like a ripple effect.
The walk leaders.
It's like a pebble in the pond.
Yeah. And Carmel, last but not least.
Yeah, I mean, I know Laura's talked a little bit about what was happening within the world of general practice, which was where we were working as well, but I think just to reiterate what's been said about the team, we also had quite a large team, and I think there was just a huge amount of learning from within the team and across the team and from outside the team as well. We had Galway, Trinity, RCSI, ourselves at Queen's, we had PPI, we had someone who was starting out on their research career who went on then to get a PhD as a result of the study they'd worked on. We had 2 postdoctoral fellows, one of whom had left research and had come back, and she took up a maternity cover for the PolyPrime study. At the end of that, then she went on to get another postdoc at Oxford and has since gone on now to get another postdoc at Trinity. So that has really, I think, provided her with a pathway back into research again. And I think, as I said, we all learned from each other, and there was such huge expertise. We had the great fortune to be working with the Primary Care Research Network, very ably led by Mrs. Claire Leatham, who's in the audience, and also the Clinical Trials Unit, and Ashley Agus, Dr. Ashley Agus is here today as well. And they were just fantastic in terms of really demonstrating to us how you do research under particular circumstances, be it within general practice, which Claire knows like the back of her hand, along with her colleague Marina, and again with Ashley and her colleagues, this is how you run a trial, this is what you need to do. But we also had established an external steering group to give us independent advice, and again they were fantastic because they were coming at it from a slightly different perspective, but were also very, I think, appreciative of the difficulties that we were facing because of COVID and because of some of the other challenges that people have mentioned. And I think we all really gained from that. Plus we had clinicians on the team. We had 2 very experienced GPs who were able to tell us, you know, this is what we're currently facing in practice. And we knew we were going to have to change our intervention, but we just weren't quite sure how we were going to be able to do it. And they said, well, we think this might work. And as it turned out, it did work. So I think it was a fantastic exercise in building a team to be able to do a high quality study in primary care at the most difficult time, probably, I think, any of us have faced.
Amanda, I think you've one last question for the panel, and I know we're under a bit of time pressure, but this is so important. It's PPI, so.
Yeah, no, so and thanks so much. That's been fantastic to hear about all the capacity building, training of all the different participants and team members. And some of you touched on the whole aspect of public and patient involvement in research, and I think it would be amiss of us to just not touch again on this, and maybe if I could just ask for a couple of examples, and maybe I'll call on yourself, Leanne and Laura, just to give us, if you could just tell them about the YAG, we've heard so much about, and I know there was a lot of activity from My COMRADE Plus on the PPI activity. I suppose it's just to give an oversight and to see and to tell the audience here today what were the real benefits that engaging and really putting a lot of effort into the PPI activities, what that brought to the study. It would be great. Thanks.
So the WISH study had PPI embedded from the beginning, and it was through a youth advisory group. So we had 3 YAG meetings over the study, and the idea was to involve young girls in the design, the implementation and the dissemination. So the very first YAG meeting, young girls were invited from schools, and we asked the schools to bring girls that were 12 to 14 years of age and 15 to 18 years of age, because that reflects the age of the participants and the walk leaders for the WISH study. So it was really important to get their perspectives. We're a bit older than those girls, so we're unaware of what is going on in schools and the things that would get these girls engaged in research. So they were able to raise concerns about implementation, and where possible then we were able to make changes. So they talked about having incentives to incentivise wearing accelerometers and returning accelerometers. So they came up with the ideas of the different incentives to be used, and then those incentives were used as part of the WISH study. Another thing that they were involved in was, so the walk leaders, the older girls, said that if they were to be a walk leader, they don't want to take away from the time that they would spend with their friends at break time or lunchtime. So what we did as part of the walk leader training is we worked collaboratively with the walk leaders to devise the walk-in timetable, and they could then self-select themselves for a particular spot so that they could do that with their friends, and they were contributing to the study while it wasn't taken away from their time as well. So we had hoped that this would help with the engagement. So they really did. They helped with ideas around recruitment, and we had fantastic recruitment rates, 53%, which we were very proud of within that cohort of girls. And the dropout rate was quite low as well. So it is hard to evaluate, PPI, but evaluations that we did at the youth advisory groups was that the girls felt that their voice was being heard, and they felt that as researchers we valued their opinion, and then they could then see the changes that were made then in the actual research.
That's wonderful, thanks Leanne. And Laura, if you just wanted to touch on your experiences, that'd be great.
Yes, so you probably saw on the video there from Andrew and Carmel, so we had a PPI group of 4 individuals, 3 from the north and 1 from the south, 2 men, 2 women, who were very much involved in our study. The intervention on My COMRADE Plus was conducted by clinicians, but it was very important, obviously, that the study materials were appropriate to the patients who were consenting, and we got a lot of their input, for example, on things like a lot of people, I suppose, like that kind of personal touch of their own GP being kind of mentioned on the kind of the study materials and things, and it not being too wordy or kind of too much jargon. And then we kind of combined that as well. Additionally, there was a qualitative element of our study, just asking, for example, what patients would like to know after a GP has reviewed their medications. So an example of this was some people, there were no changes to their medications made, but patients would still like to have heard that, as I say, just to keep them updated. So really important, I suppose, for going forward.
Looking to the future. So to some extent, we've been looking at these studies through the lens of cross-border research, which is important. And there are future opportunities. Obviously, we heard a little about Future Interreg, Peace Plus. There's also the Shared Island Initiative. But also, let's think about these studies as being really good research. So I don't know how aware everybody is, but both HSCR&D and HRB operate reciprocity, so that researchers based in any institution on the island of Ireland can apply to either organisation. And obviously HSCR&D has to operate within the context of the UK health research system, so there are fewer calls and types of calls. But HRB has a full range of different kinds of funding for projects or individuals. So a funding body is only as good as the proposals it receives. So I'm wondering whether any of the researchers who have led CHITIN studies have made further applications. Have they been well received? We've heard wonderful examples of great research, interdisciplinarity, great PPI, great, for example, external advisory bodies, other training elements, etc. And so I would like to hope that we could hear of some future successes.
There are certainly schemes in both jurisdictions that are open, and this is a great example of one of them, and we do have quite a lot of collaborations with researchers working together on both sides of the border. So yeah, it's really enriching to work with our partners in HRB.
Bernie, I think it's probably easier for academics to lead research studies, but I think one of the things that we have found in our trial is that we have a really research-engaged clinical workforce, but there are still some barriers in their way to engaging fully and in them leading studies, because the best questions to be answered are the clinical questions that arise from everyday clinical practice. And the therapists on my study have used this period of time to equip themselves with the knowledge and skills, and really they have some plans to use discretionary funding to start to submit their own applications, but probably what would be very helpful would be dedicated time out of clinical time to be able to spend time developing those proposals, and also maybe champions in their workplace, research champions to help them, or for them themselves to become research champions to lead these studies, because I think there is so much in terms of knowledge and skills in the clinical workforce, but they're under so much pressure to deliver services and to deliver post-COVID particularly, and with reorganisation of services, it's not always straightforward for clinical research. So I think my plea would just be maybe if we can make some knocks on doors for dedicated time and research champions in the clinical setting.
And with budgets under pressure, you know, these types of funding opportunities are really important for us to be able to look at those different ways of making research happen. Thanks again, Bernie. And actually, I think that sort of leads me very nicely to what I was going to say in summing up. So first of all, I hope that today's event really helped to demonstrate exactly how the research teams met the brief. I think across all the research teams, they delivered everything that we asked them to against such a challenging backdrop. All of the diversity of populations and settings, the PPI, the capacity building, it's been an absolutely amazing programme to watch it unfold and to be part of. So I'm really proud of everyone who was involved, including the research teams and our colleagues and our partners in HRB, the team within the office, and every participant and our PPI colleagues. I'm just really proud to have been part of this. And so I think it's very fitting that we've had this celebration event today at the end of the programme, and I'm absolutely delighted for all of you to have attended today and taken part in the event. So thank you so much. Ourselves, HRB, we'll continue collaborating, and we do hope to deliver more cross-border projects into the future. There's no doubt that we will be looking for opportunities to do that between ourselves and hopefully be able to support you in the way that you would like in future, against as well a very challenging financial backdrop. But I think that there's a lot of learning has come out of the CHITIN programme, and there's a lot that we can do in different ways now that might actually help to deliver more for less as well, perhaps, into the future.